Hi, here we are at Move Better, Feel Better. I'm Cynthia Allen. This is the Feldenkrais Awareness Summit. I'm really pleased here to have this whole track on breathing, actually. I've been very excited about it. I have been excited about it since before I even thought about the whole rest of the summit because it's an area I've been interested in for a few years and been involved in an interdisciplinary group. And we have with us Patrick I'm just going to mess it up, Patrick. I'm going to let you say it when we get together here.
You're fine. Yeah.
And Patrick is one of those people that a lot of us started out with an issue. As a child, he suffered with asthma, persistent wheezing, and tightness in his chest. And at the age of 16, he ran across an article about Dr. Pateko's approach to breathing. And just from that article, he came up with a strategy to start giving him some relief. He's gone on, of course, to study and become a best-selling author of several Amazon books. And his newest book, The Breathing Cure, it's a deep dive into the science of breathing. It explores functional breathing for a wide range of health conditions and breathing exercises suitable for adults, children, and teens. This unique set of exercises improves the quality of life for sleep, health, and performance. As well, you might also be interested in Patrick's 2015 book, The Oxygen Advantage, already available in 14 languages. So welcome, Patrick.
Cynthia, thanks very much. That's a very extensive bio. It's nearly embarrassing listening to it. And thanks very much for your interest in breathing. I really think it's a field that was overlooked in so many different modalities. And I'm hoping over the next hour or so that we can kind of explore the relevance of breathing to movement and to other aspects, including sleep and anxiety. And I suppose the human body is very much interconnected, that if
Yes,
one
yes.
function such as breathing is off, it can have impacts on other functions. And we need to look at the body as a whole.
Yeah, so you're going to help us break open this topic of maybe really connecting it from functional breathing to functional movement, I know. But I'd actually like to start with why in the world have we had so much trouble recognizing the importance of quality breathing? It seems so obvious.
It does, but at the same time, air is weightless. And you can have subtle differences in breathing that aren't necessarily so obvious, but yet that subtle change can have an impact in that person's life. And like, this is not new information. Originally, a subset of breathing pattern disorders is chronic hyperventilation syndrome. And it was first recognized during the American Civil War by a military physician called Da Costa. And he noticed that soldiers returning from the front line, they exhibited symptoms of breathlessness, they had difficulty sleeping, they had reduced pain thresholds, increased pain perception, and he found that their recovery was a long time. And he called it Da Costa syndrome. And then in 1937, that name was changed to chronic hyperventilation syndrome. And different names came out, but in the 1960s, medical doctors said it wasn't their field and they handed it to psychiatry because they thought it was more of a kind of a mental, a psychophysiological aspect. And the psychiatrist said it wasn't their domain. So they handed it back to the medical doctors. And according to chest physician Claude Lum at the time, who developed a breathing method in his work as a chest physician, he said that chronic hyperventilation syndrome and breathing pattern disorders, it fell between the two stools of medicine. So no modality wanted to claim it.
Mm.
And there's another aspect as well. There's a lot of people teaching breathing and they don't have an understanding of basic physiology, which is unfortunate because, you know, I remember growing up, I was a chronic mouth breather, constant nasal obstruction. I had terrible fatigue, poor concentration. Your mood is impacted. You're difficult to do physical exercise because you have disproportionate breathlessness. And nobody told me to breathe through my nose during that time. And even after having a nasal operation to reduce turbinates inside the nose so that I could breathe easier, nobody told me to breathe through my nose. So despite having the operation, I still continued with the behavior of mouth breathing because, of course, it's not just enough to fix the nasal obstruction. We also need to change the behavior. Breathing probably has had a bad rap because it was often seen on the fringes of society in terms of, more kind of people left of field. And I it really has a great fit in conventional management. But another aspect is that research is, as you know, as I know, is primarily going to be funded by pharmaceutical industry, and industry is not going to want to research into breathing. But the last 5 years, I have seen a fundamental change, and now breathing is getting out there. And if we look at the work of the book by James Nestor, who wrote a wonderful book, and he wrote a book based on what we knew for 20 years. And his book has reached New York Times bestseller. His book has gone into many different languages. So it's through books that we're getting this information now into the hands of the general public. And I actually think this is going to be a push from the grassroots upwards.
Yeah, I
Um,
think, James Nestor has also got a talk here in the summit, so we're really excited about that as well. And, sometimes you get these opportunities where someone like him helps to push something forward into the general consciousness. So
yes, yes,
I think it's a great time for us as human beings to be able to improve something so fundamental. And
yes.
I can see why people think, look, it just happens naturally. There's always this thought like, those things happen naturally. We don't have to interfere with them. Well, of course, they happen naturally in the way that they happen. But if we think about breath as being the most fundamental aspect of nutrition that the human being needs, then any kind of little bit of tweak or improvement in it, it seems like it's going to have a really big impact.
Well, if we look at breathing, we need to look at breathing a little bit deeper than what is often observed. The one issue with breathing is that it's often being traditionally taught according to tradition. The yoga instructor who learns their instruction will typically follow that, and they don't deviate outside of it. My background is Buteyko method, and I focus primarily on the biochemistry of breathing, but I neglected the biomechanics and I neglected resonance frequency breathing. Yoga instructor and Pilates instructor is mainly focusing on the biomechanics, but they don't necessarily focus on the biochemistry and they don't look at the resonance frequency breathing. And then HeartMath or heart rate variability instructors, they're focusing on coherent breathing, resonance frequency, but they're not looking at the biomechanics and the biochemistry. And it's really important to look at the three links. And what I'm going to do is just do a quick share here. Um, because we cannot think of breathing just as isolated to one dimension. We have to look at the interplay here. And we see in the middle here that nasal breathing is the key. When we breathe through the nose, for example, we tend to have better biochemistry because the nose during wakefulness imposes a resistance to our breathing to slow down our breath to help ensure a better blood gas balance. Nasal breathing also activates a greater amplitude of the diaphragm. I often say to my students, take a look at your chest and breathe through your mouth. And when you mouth breathe, you typically will activate the upper chest. Nose breathing is essential to ensure a long-term outcome in terms of recruiting the diaphragm. Nasal breathing also slows down the breath, and this helps then with improving resonance frequency breathing. And this way we can tap into the autonomic nervous system to help achieve a balance between the parasympathetic and sympathetic response. Now, they're all interrelated because if we breathe light, it's easier to breathe low. And if we breathe low, it's easier to breathe slow. And if we breathe slow, it's easier to breathe light. So the acronym that I use is to breathe light, slow, and deep. And it's not enough just to bring breathing into how we are breathing in a studio, but it's how do we breathe during rest, during physical exercise, and during sleep. But ultimately, how we breathe during physical exercise and sleep is determined by how we breathe during rest. And physical exercise doesn't improve our breathing patterns.
Mm.
So, the question then is, well, how come people do have poor breathing? Well, look at the incidence of it. I'll pull up a couple of papers because it's starting to get more attention in terms of functional movement. And I'm going to pull up a paper by Kiesel, he's professor of physical therapy from the University of Evansville in Indiana in the United States. So he looked at 51 subjects and they were 27 years of age, a BMI of 23. And he looked at their breathing from typically what researchers do when they look at breathing is they look at from a biochemical point of view. That's investigating end-tidal carbon dioxide or carbon dioxide in the blood. They look at it from a biomechanical point of view using maybe the high-low test. In other words, is the person breathing high using the upper chest, or are they breathing low with good amplitude of the diaphragm? And they also look at it from a psychophysiological point of view using an Nijmegen questionnaire. Now, out of the 51 subjects, only 5 of them had normal breathing. Now, given these are young people, 27 years of age, 14 failed at least one measure, 20 failed at least 2, and 12 failed all 3. Now, the purpose of this study was to develop a screening protocol to identify individuals with dysfunctional breathing. The conclusion was from Professor Kiesel that using a breath hold time, and that's something that we've been using again, standard for 20 years, that you have your student sit down for say 5 minutes until their breathing, it kind of normalizes. And then you ask your student to take a normal breath in and out through their nose, to pinch their nose and to hold their breath. And time, how long does it take until the student feels the first definite desire to breathe or the first involuntary movement of the breathing muscles? And Professor Kiesel's conclusion here was that if you have a breath hold time of above 25 seconds, there is an 89% chance that dysfunctional breathing is not present. Now, if you look at his paper here, you will see that he's talking about that dysfunctional breathing is as high as 50 to 80% of the adult population. The term dysfunctional breathing has been created to identify those individuals who display divergent breathing patterns. And normal breathing is really about breathing through the nose, driven by the diaphragm. It's regular. Dysfunctional breathing has been linked to a number of common conditions, such as lower back pain, neck pain, anxiety, and depression. And it has been reported that approximately 50% of individuals with lower back pain, 50%, and 83% of individuals with anxiety demonstrate some form of dysfunctional breathing. So it is present, and it's more present in some sectors of the population than others. So a Cochrane review back in 2013 said it's about 9.5% of the population. I would believe it to be more. But in asthma, studies have showed it increases to as high as 30%. I would believe it's more for that population. But for anxiety, it's as high as 75%. Professor Kiesel cites a paper there, 83%. Lower back pain, 50%. So we have to ask this question. Breathing, if, for example, we get anxious, it is true that anxiety is going to change our breathing patterns. We are going to breathe faster, a little bit more upper chest, maybe a little bit more regular. We stop breathing or we're sighing, etc. It's not just that anxiety is changing our breathing patterns, but it's our everyday breathing which is feeding back into anxiety. And it's the same with lower back pain. It's the same with neck pain. So if we have poor breathing patterns and we have overuse of the upper chest, and we're not generating intra-abdominal pressure with functional movement of the diaphragm, we're not achieving spinal stabilization and postural control. It's very important that, for movement, we also have normal breathing. And it starts with breathing in and out through the nose. And unfortunately, in the adult population, I can only come across one paper looking at 9,000 individuals in Japan who answered questionnaires, and it was concluded that 17% of them were mouth breathers. Now, mouth breathers will typically breathe using the upper chest. Mouth breathing during childhood, it leads to craniofacial abnormalities, forward head posture, etc. And the problem with this is that the changes that happen in the musculature of children as a result of breathing through an open mouth, those changes tend to be lifelong. And there's a knock-on effect. The face changes because the tongue isn't elevated in the roof of the mouth. The jaw, the maxilla, is not far forward enough in the face. The mandible is set back. The airway is compromised. These children are pushing their head forward to try and open up the airway. These kids have an increased risk of obstructive sleep apnea. And then if we look at the impact that obstructive sleep apnea is having on overall health, including diabetes, cardiovascular health, and even dementia. So, we do need a need for awareness, and this stuff is not new. This has been written about in dental journals since 1909. One journal around at the time, the Dental Cosmos, spoke of children who were sitting in class with their mouths open. These kids, in quote, inattentive in school. They have dull and expressionless faces because if the face doesn't develop correctly, we have a longer face and a flatter face. We don't have high heat cheekbones. We're more likely to have a crooked nose like mine. We're more likely to have the jaw set back. We don't have a nice definition. We have a double chin. So all of those things are out there. None of this stuff is new. And really, this is where we need the awareness. And, I'm thinking about your instructors, for example, who really, it would be important to achieve functional breathing patterns. And we have to look at what can we achieve or what can we influence through the breath.
Yeah, so I just like to throw in there that I think we happen to be somewhat lucky in the Feldenkrais world in that we don't explore one way of breathing. So
Yes.
we have huge varieties of lessons that explore all kinds of different ways of breathing, and almost always they're also exploring those different kinds of ways to different types of functional movement. So I think we aren't predisposed to getting people hopefully into a really bad habit, um, where they adopt one kind of breathing only. But we really don't know much about what is I guess what I would call maybe the everyday normal
Yes,
breath
yes,
breathing
yes.
pattern. And
Yeah.
I think this whole rap about breathing not for me personally, a really simple demonstration of the difference between mouth breathing and nose breathing is when I have a cold. When I have
Yes.
a cold, if I make sure I tape my mouth closed for the night, when I wake up in the morning, I feel fantastic.
Yes. Yeah.
But I go to work and I start talking all day long, which means I start breathing in and out of my mouth because I'm talking all day long. My nasal passages become so congested that by
Yes.
the time I'm able to sit down again at night and start saying, "Okay, breathe through your nose," and like everybody else, I have a little moment of panic about that. But then it turns out if I keep playing with it, within easily 5 to 10 minutes, I'm able to breathe through my nose again. It opens. So I just love your all's work. It's how practical it is that what we're not using, we do lose.
Mm.
And then if we just keep re-engaging with it, find ways to re-engage with it, we can open up more functional opportunities for ourselves.
Yeah, for sure. And, I think it's maybe important to even talk about a few of the breathing exercises. For example, if somebody comes in with labor breathing, I receive emails with people who are recovering post-COVID and they have long COVID. And when we measure their breath hold time, it can be as low as 3 seconds. And these people, they can't string a sentence together. They're continuously breathless. Now, with that group of individuals, we need to give them very specific gentle breathing exercises. They already feel suffocated, they already feel air hunger. So, with that exercise, with those people, then we start them with breathing recovery. Very simple exercise. Anybody can do it. We have the person take a normal breath in through the nose and out through the nose and pinch the nose and hold the breath for 3 to 5 seconds. 1, 2, 3, 4, 5. Let go and breathe in through the nose. Breathe normal for 10 seconds. And again, normal breath in and out, pinch the nose and hold. Hold the breath for 3 to 5 seconds. We do that to have a calming effect on the breathing, with the objective being to slow down the respiratory rate. The second exercise that we look at is decongesting the nose. It's been known since 1923 that if you hold your breath, your nose opens up. And it's not known exactly how it happens. There are some papers showing that it's increased carbon dioxide. So any of your listeners who have, or viewers who have nasal congestion, I'd like you to try this. Don't try it if you're pregnant, or don't try it if you've got serious medical conditions, because it's important that you recover your breathing afterwards. But it's a relatively safe exercise. To decongest your nose, first of all, you could test which side of your nose is more obstructed. Try your left side of the nose and then try the right side. So you take a breath in through the right side and a breath in through the left side. You could use a mobile phone. And for example, you do the fogging test. You breathe onto your mobile phone, you clean the glass, breathe onto the glass, and just look at the halo that's left. And that will tell you which side of the nose is more obstructed than the other. To decongest your nose,
I just needed another way to use my mobile phone. I just had to
yes, and it's probably a more valuable use than most people stuck glued looking at it. But to decongest your nose, you can easily do this. Take a normal breath in through your nose and out through your nose, pinch your nose and hold, and just gently nod your head up and down, holding your breath. As you hold your breath, and just gently nod your head up and down, holding the breath, or you could sway your body, or you could even walk around holding your nose. And then you let go and you breathe in through your nose. So the objective here is to hold the breath after an exhalation until you feel a moderate to strong air hunger. And at the end then is to let go, but to breathe in through the nose. Wait a minute with about normal breathing, and then do it again, and repeat it 5 or 6 times. And the nose will generally be much freer. So we know that that is true. And we also know that people with a breath hold time of less than 20 seconds are more prone to nasal obstruction, but they're more prone to coughing, wheezing, breathlessness. So the breath hold time that we use, we call it Bolt score in the oxygen advantage, or it's the control pause in the Buteyko method. And this is the screening protocol that Professor Kiesel used. It's simple. So your listeners or viewers they need a watch or they need a mobile phone or something to time it. They take a normal breath in through their nose and out through their nose, and they pinch their nose. And they time it in seconds. How long does it take until they feel the first definite desire to breathe or the first involuntary movement of the breathing muscles? And the objective is that their breath hold time during rest is above 25 seconds. And individuals with asthma, for example, it's a very good indicator of breathlessness during physical exercise. So, as I said, the person with COVID having a breath hold time of 3 seconds, all she could do, take a normal breath in and out, hold her nose, and 3 seconds later, she feels a need to breathe. This lady cannot walk. She doesn't have exercise tolerance. She's not able to talk. Her respiratory rate is elevated. So the lower the breath hold time, the faster the respiratory rate. The lower the breath hold time, the more likely we are to use the upper chest. And individuals with chronic hyperventilation syndrome, which is a subset of breathing pattern disorders, tend to have a low breath hold time. So I think breath hold time could be a very good, simple tool to bring in to assess the breathing patterns of clients. Of course, it's not perfect, but I've used it with 8 or 9,000 people, and it's pretty good. So when I have a student in front of me, I measure their breath hold time, but I also observe their breathing. But I kind of do it without staring at them, because if you stare at somebody's breathing, of course, they get stressed and their breathing goes anyway. Um, I want to see, are they breathing upper chest or are they breathing low? I want to see, is their breathing regular? And I want to see what's the tidal volume of the breath? How fast is the respiratory rate? And do they have a natural pause following exhalation? And I put a new ABC breathing classification into the new book. And it hasn't been validated, because the only reason I put it together was because there is no classification of breathing. So I graded it: normal ventilation, grade 1, grade 2, grade 3, grade 4. And predicted outcomes: breathlessness during rest, breathlessness during physical exercise, forced expiratory volume, etc., breath hold time, respiratory rate. So I brought that in together, and that may be useful, and maybe in time it gets validated. So then, looking at it from a biochemical point of view, for years I had cold hands and cold feet. And I never realized that the reason that I had cold hands and cold feet was because I was mouth breathing and fast and shallow breathing. I never realized that my blood circulation was influenced so much by the fact that I was breathing too hard. And I remember starting when I did the nose unblocking exercise, and I opened up my nose and I felt suffocated breathing through my nose. And as you said, it is a case of use it or lose it. I kept on breathing through my nose, and I kept on doing the exercise, and I kept on slowing down my breathing. And my body got accustomed then to nasal breathing. And I have to say, it was the best thing I ever did. In terms of the mind, I was calmer, because it's not just that anxiety is causing fast upper chest breathing, but fast and upper chest breathing is causing agitation of the mind, but it's also more likely to awaken us from sleep. If we look at the research by Stanford Medical School in March of 2017, they identified a new structure in the brain which is spying on our breathing. And if we breathe fast, this structure in the brain is relaying signals to the rest of the brain, and it does arouse us from sleep. So people who are more prone to insomnia, for example, they're lying in bed, they're asleep, but their breathing is getting fast, maybe they have asthma, etc., they're more likely to wake up. So the other aspect was taping them out at night. And I started taping my mouth 20 years ago. And that night, but the first night I used Breathe Right strips as well, because my nose still hadn't adjusted to fully, working properly. The first morning waking up, I was kind of getting used to it. The second morning waking up, it was a sleep that I had never experienced before. This is not new information. It's been written about for 400 years that mouth breathing has negative consequences in sleep. Now, obstructive sleep apnea is a condition that we should all be looking out for. And it is a condition that, it has been overlooked for many years. And it's estimated that 90% of people with obstructive sleep apnea are undiagnosed. But the implications of this condition in everyday life and quality of life, including fatigue, but also depression. So, I can always, and I wrote about this in the book, as, a woman coming into me and she was in her 30s and she has depression. And I asked her, I said, how do you feel when you wake up in the morning? And she says, I wake up feeling absolutely exhausted. And I said, has any healthcare profession asked you, how do you sleep? And she said, no. And I think the reason being is because here we have a 30-year-old woman, or she was in her mid-30s. She's exhausted. And most people are assuming that it's the depression which is causing the exhaustion. But maybe we have to consider that this person has obstructive sleep apnea or hypopnea or insomnia. And when insomnia and OSA, obstructive sleep apnea, go together, there's an increased risk of depression. So here this woman is going from psychologist to psychiatrist to medical doctor. Nobody has looked at their sleep. Nobody has looked at her sleep. And all that time, sleep and breathing has been overlooked. So I want to show you this. This was a recent study published in the Laryngoscope in May of 2020. They looked at 95 individuals with established obstructive sleep apnea. And obstructive sleep apnea is when we have collapse of the upper airway during sleep, and it's lasting for more than 10 seconds. Now, if I scroll down to look at the AHI index, which is a measurement of sleep apnea severity, but if we look at mouth breathing here, 95 individuals, 11 of those were mouth breathing solely. And if we look at their AHI index, their AHI was 52 events per hour, it's really severe. Individuals breathing both through the nose and mouth or switching from mouth to nose breathing, they comprised of 49 individuals, or 51%. Now, if we add up the individuals who are breathing solely through their mouth or switching from mouth to nose breathing or breathing through both, we have a total of 62%. Only 36% of people were nasal breathing. The AHI index with people who were nasal breathing was 27 events per hour, which, it's moderate and it's bordering on severe, but 27 events per hour is still a lot less than 52 events per hour. And if we tie this in with breathing, if we have faster and harder breathing, or say somebody with respiratory conditions such as asthma, we know that as asthma severity increases, so does obstructive sleep apnea. And doctors traditionally, when they're looking at sleep, they only look at the airway, but they don't look at flow. Now, I often use the example, or I have my students, I say, take a breath in through your mouth, and I'd like to make the sound of a snore, and it goes like this. And now I say to them, close your mouth and try and snore through your mouth. You can't. And now I ask them to make the sound of a snore through the nose, and it goes like this. Now what I say is, start slowing down the speed of the air that you're breathing in. And this also would be an exercise, and I'll do it for a couple of minutes because I'd like people to feel, can we improve the circulation in your fingers by simply slowing down the breath? So I'd like your viewers to start slowing down the speed of the air coming into their nose, almost breathing as if the air is imperceptible. And at the top of the breath, have a really relaxed and a slow exhalation. And then after you have a slow and relaxed exhalation, breathe in very softly in through your nose, just focusing on the airflow coming into your nose and gently slowing down the speed of the air entering the nostrils, almost as if you're hardly breathing. And then you have a relaxed and a slow exhalation. As you breathe slowly, try and snore through your nose. And you'll see that as you breathe slow, snoring through the nose is much more difficult. Snoring in obstructive sleep apnea and upper airway resistance syndrome is not just due to an anatomical problem, it's also due to flow. And no engineer looking at the diameter of a tube will focus solely on the diameter of the tube. That engineer is also going to question flow. Now, flow is the speed of our breathing, whether we're breathing up our chest and how hard our breathing is. And that's why breathing during rest. Now, coming back to that
I just wanna
exercise,
say that
yes,
I can feel that that is impossible for me to make a snoring noise through my nose going that
yes,
slow. I can't do it.
yes. And it makes sense. And then when we look at people with asthma who typically have a low breath hold time, people with anxiety, 75% of the population. And if we look then at the interplay, and I'll come back to that exercise because I'd like your viewers to give it a go. And it's a little bit different of an exercise because it's involving what happens when you deliberately breathe less air to the point that you feel air hunger. And we should talk about carbon dioxide and oxygen on the basis of that. But in terms of, if we look at functions of sleep and breathing and the mind, when the mind is agitated and we're in that sympathetic activation, sympathetic tone, and we go to sleep that night, it's difficult to fall asleep because the mind is ruminating on thoughts and we're going from one thought to another. So an anxious mind is impacting sleep. And if we have poor quality sleep because of insomnia and difficulty achieving a deep sleep, we're going to have an anxious mind. So anxiety and sleep feed into each other. Now, if we have poor breathing patterns and we're breathing through an open mouth, 50% of the adult population wake up with a dry mouth in the morning. These individuals are more prone to snoring, obstructive sleep apnea, but not only that, their moisture is being sucked out of the airways. You've got cooling and drying of both the upper airways and the lower airways. Also, mouth breathing is activating the upper chest. Upper chest breathing is reducing lung volume. And the diaphragm breathing muscle, of course, is also linked with the upper airway dilator muscles in the throat. Now, given that 26% of men under 50 years of age are prone to obstructive sleep apnea, and 43% of men from age 50 to 70 are prone to obstructive sleep apnea. Almost 1 in 2 men over 50 years of age are prone to this condition. With females, it's 9% of females up to 50 years of age. But once the female postmenopausal women, it increases by 300%. Now, so we have sleep, we have breathing. If we have dysfunctional breathing patterns, it is going to lead to anxiety of the mind because we're physiologically in that state of sympathetic tone. So we have anxiety of the mind. Anxiety of the mind is going to impact our breathing. How we breathe is going to impact our sleep. So we see that there's an interconnectedness there. And I just can't help, the amount of people with anxiety, with all of these different complaints, and they're going from person to person. And what's often overlooked is the quality of their sleep, even the simple thing, whether they are breathing through their nose or mouth. And one of the founding fathers of sleep medicine is a French medical doctor who passed on in 2019. He was a Stanford-based medical doctor called Dr. Christian Guilleminault. And he coined the phrase obstructive sleep apnea, and he developed the apnea-hypopnea index. In the last 5 years of his life, he wrote papers and he spoke of, in quotes, the critical importance of restoring nasal breathing, both during wakefulness and sleep. And he said it's the only valid and complete correction of pediatric sleep disorder breathing. Now, we know that between 25 to 50% of studied children persistently mouth breathe. And these children, if they are mouth breathing and if they have compromised sleep or sleep disorder breathing, it's impacting their cognitive development. And a study by Karen Bonnock in Stratford-upon-Avon, 11,000 children that was published in Pediatrics I can pull up the paper if you like. And it looked at children with sleep disorder breathing. If untreated by age 5, these children had a 40% increased risk of special education needs by age 8. Okay, so how do we get somebody to switch from mouth to nose breathing? Well, number one, it's very important to breathe through the nose. So we show techniques to open up the nose. Number two, if a person has a relatively fast respiratory rate, when they try breathing through the nose, they often feel it's uncomfortable because their breathing is too hard. So therefore, we need to look at the biochemistry of their breathing. And with that, we can practice a simple exercise. So I often ask my students is put one hand on their chest and one hand just above their navel. And I'd like any of the viewers here as well, just to give it a go, because I'd like you to experience this. It's not just enough about me talking about it. I'd like you to experience the air hunger and just see, can we influence the internal temperature of your hands? Can you influence the saliva in the mouth? And also, can you activate the body's relaxation response in 3 to 4 minutes? Not by taking the full big breath, which is often espoused, but by doing the opposite. Don't worry if this is shallow breathing, because here the focus is on the biochemistry. So you're focusing on the airflow coming into your nose, the slightly colder air coming into your nose, and you're focusing on the slightly warmer air as it's leaving your nose. And you're focusing on the slightly colder air coming into your nose and the slightly warmer air as it's leaving your nose. And as you focus on your breathing, gently slow down the speed of the air coming into your nose. Can you breathe almost imperceptibly that you can hardly feel any air coming into your nose? And at the top of the breath, have a really relaxed and a slow, gentle exhalation. So you're deliberately having a prolonged exhalation. And then when you need to breathe in, you're taking a very soft and slow, gentle breath in through the nose to the point that you are under breathing. Slow down your breathing sufficiently to the point that you take in about 30% less air into your body. What happens when you underbreathe? Well, when you underbreathe, carbon dioxide increases in the blood, and the primary stimulus to breathe is carbon dioxide. It's not oxygen. And as carbon dioxide increases in the blood, you feel air hunger. And carbon dioxide is not just a waste gas. So again, I'd like you to really slow down the speed of the air coming into your nose, and of course to continue breathing. And at the top of the breath, a really relaxed and a slow and gentle exhalation. So slow, so relaxed. And as you breathe in, can you breathe almost that the fine hairs within the nostrils do not move, that you feel hardly any air coming into your nose, and at the top of the breath, a total feeling of relaxation. So the objective is that you're feeling air hunger. Hide your breathing
I'm
from
feeling
me.
it.
You're feeling it.
I'm feeling it.
And the whole point is to continue that exercise, say for about 3 to 4 minutes. And what we're doing is we're deliberately reducing the volume of air to increase carbon dioxide in the blood, to expose our body to higher CO2. And the objective here is to reduce the chemosensitivity of the body to carbon dioxide, because with a lower chemosensitivity to carbon dioxide, our breathing is naturally lighter and slower. And the other thing about this is that
Okay, so I need to ask a question there. So you're suggesting that we can train our bodies to be okay with more carbon dioxide?
we should be. It's carbon dioxide it's a little bit tricky in terms of the gas, but say for example, if I pull up Kiesel's paper, I'm going to pull up another paper by Bradley, who looked at functional breathing and functional movement. Now, hopefully I can pull it up fairly easy. And carbon dioxide, I know it has bad rap, and people often talk about, breathe in oxygen and get rid of carbon dioxide. But we have to consider this. When I take a breath of air in through my nose, and that oxygen-laden air arrives down into the small air sacs in the lungs, oxygen passes from the lungs into the blood. 98% of oxygen in the blood is carried by hemoglobin molecules. Hemoglobin is holding on to oxygen, but the catalyst for hemoglobin to release oxygen to the tissues and organs is carbon dioxide. And this is the Bohr effect, and this was discovered back in 1904. Now, conversely, I'll give you a story. I was going to a university in Dublin called Trinity College in Dublin. I was in my final years. This is going back to 1996 or 1995. I was very anxious doing my final exams. And I went for a 4-minute walk just to clear my head before I went into the exam hall. I had thought from listening to everybody talking about breathing that it was beneficial to take big breaths. I went for a walk and I took these full big breaths because that's all I was hearing. And I went into the exam hall and I was spaced out. My head was all over the place. I was lightheaded. I wasn't able to focus and I wasn't able to concentrate. What did I do wrong? I breathed hard because I believed that the more air I breathed, it would increase oxygen delivery to the brain. But that's not what happens. What happened was that as I breathed hard, I got rid of too much carbon dioxide. And as I got rid of too much carbon dioxide, the central nervous system became aroused, but also it reduced blood flow to the brain. And not only did it reduce blood flow to the brain, it also reduced oxygen delivery to the brain. Now, Cynthia, you know yourself how many yoga studios, if you went into a studio, can you hear students breathing in class?
Yeah.
You should never hear anyone breathing.
Yeah,
Anyone
it's, you know, and
breathing.
for us in Feldenkrais, what Dr. Feldenkrais said is a healthy individual is one that can't be detected. It's because if
Well,
you need
that
to
is
be able to
super.
survive out into the wild, you don't
Yes.
want to hear yourself breathing. That's another giveaway for yourself. So just at the animal level, it makes sense that we would want to have quiet, easy breathing, not breathing that is detectable to other beings.
Yes.
And I have to
And
tell
do you
you,
know
I took.
what? I'd never heard that before. That's
Isn't that a
wonderful.
great one?
Yes,
I love,
yes.
you know,
Yeah.
he thought about all movement is originating, and breath is of course a movement. All movement is
Mm,
originating from these basic needs to flee, fight, mate, those kinds of things, right? Those four
yes.
F's. You know, and I heard about this. I took a Bukeko course about 10 years ago, I guess. I brought someone into Cincinnati for a 5-day course. And this whole thing about CO2 really blew my mind then. And I think it's still completely new information to the majority of the world. So I'm just so glad to have you keep bringing it back forward.
Yes. Like it's one dimension. And it's not that everybody with breathing pattern disorders have low CO2. But if you have an individual with a low breath hold time and a typically faster respiratory rate, we have to ask the question, how can we change the respiratory rate that it becomes slower? And we can achieve that with the air hunger exercises. And the other thing is, if we're working with somebody with panic disorder, there are two subsets of people with panic disorder. One subset is able to cope well with air hunger. The other subset isn't. And these individuals, when they feel air hunger or suffocation, it drives them into a really strong fight or flight response, and it can bring on a panic attack. So when I have somebody coming in with panic attacks, I want to find out how well are they able to cope with the air hunger. And I want to give them a teaspoon of the air hunger. I give them a teaspoon to desensitize their body towards the reaction of suffocation. So, you know, there has been studies looking at carbon dioxide, and even one by Moret, and I've written about it in the new book. She was, I can't remember her title, but she compared cognitive behavioral therapy, which is typically used in counseling, against capnometry training, which is slow breathing to increase CO2. And she said that CBT doesn't change respiratory physiology, that we do need to teach these individuals with anxiety and panic disorder to slow down their breathing, to normalize their breathing patterns, to have normal carbon dioxide in the blood. Now, I'm going to show you this paper here. So this is an interesting one because I think it ties right in with what we're talking about here, breathing pattern disorders and functional movement. Normal breathing, as you know, plays a key role in posture and spinal stabilization, and breathing pattern disorders have been shown to contribute to pain. So individuals who have a lower breath hold time and who chronically hyperventilate, they've got increased pain perception and they've got reduced pain thresholds. It also impacts motor control deficits, which can result in dysfunctional movement patterns. Now, I know the functional movement screen has its critics, but despite that, This was a study looking at 34 individuals, looking at their breathing across biochemical, biomechanical, and psychophysiological. And I'm just going to bring you down to the results here. So if I can get the figures, because just to show you in terms of carbon dioxide. So the group here, I think, was 34 individuals. And if we look at their resting end tidal CO2, it was 33 millimeters of mercury. The minimum was 27 and the maximum was 39. Normal carbon dioxide is between 35 to 40 millimeters of mercury. The respiratory rate during rest was 18 breaths per minute, too fast. CO2 was too low. Respiratory rate, too fast. The average was 12. Sorry, the minimum was 12, which would be nice. The maximum was 25. That's very, very fast. Breath hold time, the minimum was 10 seconds. The maximum was 34 seconds. Now, we spoke about earlier on, it's true, not everybody breathes the same. And look at this divergence here. A breath hold time ranging from 11 seconds to 34 seconds, with an average of 19.22 seconds. The interesting thing about this is that 87.5% of people, I won't find it in it, but 87.5% of people who passed the functional movement screen were diaphragmatic breathers. And the researchers found that there was a correlation between functional breathing and functional movement. As the diaphragm plays a key role in pressure generation, the change in the length-tension relationship of the diaphragm results in altered pressure generation. We know this, but how about somebody who is breathing predominantly fast using the upper chest? So furthermore, 87.5% of individuals in the PASS group were classified as diaphragmatic breathers. Now, that comes back to looking at their breathing also from a biochemical point of view, because if I'm an individual with a fast respiratory rate such as 18 breaths per minute, it's too fast. If I switch to nose breathing, I'm going to feel very uncomfortable because I've got an increased sensitivity towards carbon dioxide. And with those individuals, we give them breath holds, gentle breath holds, slow breathing, reduced breathing, but we also teach them resonance frequency breathing to simulate the vagus nerve and to improve the sensitivity of baroreceptors, to improve what's called heart rate variability. So we're looking at the breathing from a biochemical point of view, biomechanical point of view, and also in terms of heart rate variability. And I do think it would be a mistake that if I was to work with a student and to focus solely on breathing low, which would be wonderful, if I didn't tell them or show them how to change to nasal breathing and nose breathing both during rest, during physical exercise, and during sleep. So I think, just that thing about breathing, it's it's simple, and yet it's not so simple. And, I'm 18 years working with it. And the one thing I realized that the longer that I work with it, the more I just don't know. It's such a wonderful field. And I think we're going to see advancements and we're going to see greater recognition. And we do need more research. There's no question. But first, do no harm, And the other aspect, Cynthia, is maybe 50% of your viewers' clients are female. Female breathing is very different to male breathing. And this has been written about since 1905.
Well, I would say
But
most of us have a predominantly female practice, and we know that who's showing up at the summit is predominantly female. So can you just say a little bit more
yes.
about that?
So say younger females during the monthly cycle, there's a change in hormones, which is not prevalent in males. So post-ovulation, between days 10 and days 22, during the luteal phase, there's an increase in a hormone called progesterone, which is a respiratory stimulant. And it can increase breathing, that breathing becomes faster and harder to the point that carbon dioxide levels drop by as much as 25%. Now, if carbon dioxide levels are dropping by as much as 25%, that's going to arouse the central nervous system. But it's also going to increase pain, and it's going to increase anxiety and the feeling of panic. So PMS is directly attributable and contributed to by breathing pattern disorders. Now, if you have a female with pretty good breathing, the changes in hormone levels they'll be able to cope with. But if you have a female who may be predisposed to anxiety or asthma, or if they have dysfunctional breathing patterns, when they have the added change, hormonal changes on top of their already poor breathing, it's going to have an added impact. The second aspect then is postmenopausal women. So their sleep disorder breathing, it increases by 300% and post-menopause. And we have to think of the connection here between the diaphragm. It's known that obesity and OSA increases obstructive sleep apnea. And when we put on weight, yes, it's true that we have fat deposits on the throat. So the airway becomes narrower. And we also can have fat deposits on the tongue. And the tongue, therefore, can occupy more space in the mouth and encroach the airway. But we also put fat deposits on the belly. And when we put fat deposits on the belly, it impinges the movement of the diaphragm, which in turn then is leading to more upper chest breathing and faster breathing patterns, which in turn is reducing lung volume. And as a result, the throat is more likely to collapse. So when we look, sleep medicine has really changed in the last 7 years. And traditionally, it was seen that obstructive sleep apnea was primarily anatomical. But now there's a recognition that there's one anatomical characteristics and three non-anatomical. And breathing plays a role with that. So if you have an individual breathing fast and hard using the upper chest, they're going to have increased negative pressure in the airway. If they have the mouth open, their tongue is more, it's not going to be elevated in the palate. And we also then, there's another aspect there, correct tongue resting posture for mobility. And before I forget about, but I remember in 2016, I was in a conference in Rome, and one of the Italian doctors, it was a medical conference, he showed a video of a patient walking down a corridor, and the patient had a poor gait, wasn't very mobile. The doctor stopped the patient and got the patient to press his tongue up in the roof of the mouth and breathe through the nose and had the patient walk. And we couldn't believe it because we were seeing a change in the person's mobility just by correct tongue resting posture. And then we have to ask the question, how many people do physical exercise with their mouth open? And
A lot, a lot.
can you can you
And
have your
and
tongue up there
yeah,
with your
yeah,
mouth
and
open?
not
You
only do
can't.
a lot, but they'll really defend that it's necessary. So I actually wanted to ask you to talk about that as well. But I see you're making the connection to the tongue, and of course, what I've been playing around also with the tongue position, and it's clear that it immediately engages a kind of core stability when the tongue is
Yes.
at the roof of the mouth. It engages pelvic floor health. So I've been playing with it for a variety of things outside of the fact that it changes something in the structure of the musculature, the scalenes, the shoulder blades, the upper chest as well. It really changes a lot.
Yeah, it's amazing. It's amazing the organ, the tongue, and I was a mouth breather. I switched to nose breathing in 1998, but I didn't have correct tongue resting posture. I was in Texas and I was talking to a woman called Karen Samuel, who is a myofunctional therapist. And just to come up in conversation, I asked her, I said, Karen, I said, where should the tongue be? And she said 3/4 of the tongue should be resting in the roof of the mouth. And before that, my tongue wasn't. So I then had to make a conscious observation and awareness of keeping the tongue up there and also to wake up with the tongue resting in the roof of the mouth. Because if we look at the anatomy of the airway, so here we say we have the nose and we have the lips, and here we have the tongue. The tongue should be resting in the roof of the mouth. And if it isn't, it's going to more likely encroach on the airway. And the airway can collapse in a few places here. We can have the soft palate falling against the throat. The tongue is falling into the airway. We can have the epiglottis falling against the throat, or we can have collapse of the throat itself. Now, here's the question. Can we have 3/4 of the tongue resting in the roof of the mouth while breathing through the mouth? So I'll always say to my students, put 3/4 of your tongue resting in the roof of the mouth. Now try and breathe through your mouth, and you'll see that it's pretty impossible. So
Mhm.
therefore, we conclude all mouth breathers, if we are mouth breathing, we don't have the tongue elevated in the palate. Mouth breathing during exercise, mouth breathing during sleep. So there's an interesting connection there. And I was talking about something else and I went off in a train of thought. So I've forgotten now where I left off.
Yeah, well, this is particularly interesting to me. And I just also want to say for listeners, if you're thinking about upgrading, we've got a special set of lessons in our upgrade package just to explore through a Feldenkrais way how to begin to get that tongue to consider being on the roof of the mouth. And there's a lot of subtleties to how the tongue rests up there as well. I'm sure you've explored some of these, Patrick. So when the tongue is pushed towards the pressure and the tongue is pushed towards the front versus the middle towards the back, these are also distinctions that make a big difference in where the head posture goes and how it connects down through the whole system. And the amount of pressure. I mean, when I first started playing with it, the only way I could get my tongue up there was to really plaster it. I mean, I had
Mm,
to suck that baby up there to get it up there. And then it was like, wow, that's a lot of muscular effort. And then in all the playing around, it was a few months in where I felt my tongue soften. And then I was like,
mm.
oh, it can kind of wave up here. It can kind of wave up here, and it doesn't have to have all that effort all the time. So there's so much there that you open up with that little piece, right? That we can
Yes.
explore. There's so
Yeah.
many,
Yeah.
many
No,
options.
the application is amazing. And before I forget, I would like to show my own tape, Cynthia. Now, it is my own tape, so I have a
Yes, I want
vested
to see that
interest.
because I saw that on your website, and I went, you know, I'm sure you're going to have very different reasons for why this tape is important. But for me, I think it would eliminate so many people panicking over the idea
Yes.
of taping their mouth. So,
Yeah.
yeah.
Yeah. And it's also, it's the one aspect of what we're teaching. We do want to ensure nasal breathing, and the nose will never fully congest during sleep once you're using it. And if you breathe through your nose, so oftentimes if people are a bit worried, like we have them breathe through their nose continuously during the day, get used to breathing through your nose during the day, and then you'll feel more comfortable, much more comfortable breathing through your nose during sleep. The tape was originally developed for children because before that we were using 3M 1-inch micropore tape across, and if a child got sick, there's a risk. So this idea then was it's myo tape, like it's developed primarily for the dental community because children with crooked teeth, if they have their braces, etc., once the braces come off, if the children don't continue nose breathing, there's about 65% or 70% of relapse of the teeth going back. So they become crooked again because the tongue, as we spoke about earlier, is the scaffolding for the jaw. And really, the tongue, of course, during the formative years is what develops the maxilla and the shape of the maxilla to make sure that all teeth are housed. So this is the tape here. It's fairly inexpensive. It's $25, and that includes international postage for 3 months for 90 strips. And this is the adults one. So I stretch it, and you see it surrounding the mouth. Now there's a tension here that's going bi-directional. And the objective here is also to activate the muscles around here as the orbicularis oris muscle. So you see also it's having a pouting effect. So the tension is bringing my lips together. But if I wanted to drink, or, if, for instance, there was any risk, well, you can also open your mouth. So that was the purpose of that, more so to remove any kind of risk and also the perception of people who might be panicking.
Right.
Um, and just before my point that I was going to say is, breathing research has moved a long way in the last 30 years. And we should be looking towards the research that has happened on heart rate variability. Because heart rate variability is an objective and clinical measure of stress. And I often use the example, like if somebody was to go to their medical doctor and say, "Doctor, I feel stressed," typically the doctor has no way of quantifying the impact of stress on that individual's body. But using heart rate variability, we can measure the impact that that stress has. And even individuals who go through a serious life event, such as, say, for example, a divorce, they typically show reduced heart rate variability. And it's known that individuals who are either emotionally unwell or physically unwell have low HRV, and they're often more sympathetic dominant. And through the breath, we can influence heart rate variability in a number of ways. Number one is nose breathing during sleep. Number two is the light breathing exercise that we did earlier on to generate a feeling of air hunger. Now, when you do the exercise, your HRV dips, but after that, your HRV increases. Number three is breathing using the diaphragm with increased tidal volume. Number four is slow breathing to a cadence of 4.5 to 6.5 breaths per minute. And HRV is a measurement of resilience, of sympathovagal balance. And this is the wonderful thing about the breath that, the science is starting to catch up with it. that we shouldn't be thinking of breathing as something that's on the fringes of healthcare. It should be a major component because how many disciplines of medicine are influenced by the breath? Respiration, the mind, sleep, movement, all influenced by breathing. And that's why, further awareness of it is really vitally important.
Yeah, I totally agree. Can you back us up? Way early in the talking, you had us clearing a nostril. Is it not
Yes.
true that we predominantly breathe out of one nostril for a few seconds, then the other, and then the other? Is that correct?
Yes, there is a nasal cycle. There's a nasal cycle that shifts probably every 90 minutes or so. And it can depend on person to person. Now, between 60 to 80% of the population have a deviated septum. I have a deviated septum. If you kind of see it, that my nose is going from one side to the other, and I've got one nostril smaller than the other. And the problem with that is that you may tend to have one side of your nose that's more congested than the other. So deviated septum can impact that, but normally both during wakefulness and also during sleep, because when we lie down at night, the nostril that's closest to the pillow typically gets congested and the other one is free. And then we twist turns, we turn sides during sleep because of the nasal cycle as well. And it's thought that the left nostril in right-handed people is activating the right hemisphere of the brain. So say, for example, if I wanted to calm down, I should block my right nostril and breathe through my left, and that'll help activate the parasympathetic response. And if I wanted to do a presentation and I want to be alert going out, I block my left nostril and breathe through my right, and that's activating the left hemisphere. And that's activating more sympathetic dominance. Now, some studies show it's not the case, but some studies have. But that's traditionally the belief in yoga, for example. So, you know, the nose is that organ that's back in the 1970s. There was an American ear, nose, and throat doctor called Dr. Morris Cottle. And he said that the nose is responsible for 30 functions in the human body, 30 functions. And if we look at the mouth, if I was to ask, does the mouth employ any function in terms of breathing? So if we see here that if we have the mouth open and we're taking that air straight in through the mouth does nothing. It doesn't warm the air, it doesn't moisten the air, it doesn't regulate volume, it doesn't harness a gas called nitric oxide, which is very important given COVID. Um, so mouth breathing is activating a fight or flight response. It's driving the upper chest. It's fast breathing. So we waste more air in dead space. And I can talk about that in terms of efficiency, which is another, it's interesting. Like, think of the nose here, because people don't appreciate the extent of the nasal cavity. I always say to the students, I say, put your tongue into the roof of your mouth like this and drag your tongue along the hard palate until you feel the soft palate. So drag your tongue, and the roof of the mouth is the floor of the nose.
Mhm.
So now that'll give us an idea of the nasal cavity, the extent of space that it occupies in a human skull. And
Interesting.
COVID, people are talking about washing hands and wearing masks. Great.
Breathing through your nose is like
Breathing through
really
the
high up there,
nose.
isn't it?
It is, and it doesn't get a mention. And there is a gas called nitric oxide, first discovered on the exhale breath of the human being in 1991. And in laboratory experiments, it stops the replication of coronavirus SARS. Now, this was a lab experiment. And I'm not saying that nose breathing is going to stop COVID, but what I am saying is that whatever chance we have of
Mm.
inhibiting or at least helping to prevent or reduce viral load, it's through nasal breathing and not mouth breathing. And one group of researchers and doctors wrote an article on this and talked about the importance of taping the mouth during sleep, because they said that if you breathe through your nose during sleep, it gives your body a chance to mount an adequate response to reduce viral load. And they spoke about that mouth breathers are going to be more prone to infection.
Mhm.
Um, so it's all really good. And I think COVID has cast some light on the importance of functional breathing patterns. And, you know, those people who may be recovering, and there are exercises. I put some of the videos up on YouTube, and one of them I put it back in March. It's had 800,000 views, and you'll see in the comments people who have had COVID you'll see directly if the exercises have helped them or not.
Mm.
So maybe that's something for yourselves, you know.
And you have a good giveaway for us too that I think is designed to help our folks that are listening
Yes,
in. Can
yes.
you tell us about that? Just what it is?
I have it's a 20-minute relaxation, a voiceover with music, talking you through the breathing exercise as you go into relaxation. So you can, the best way to change breathing patterns, of course, is never by force. It's always by allowing the breath to soften and slow down to get air hunger with relaxation. So that's a 20-minute voiceover that's
Beautiful.
available.
Beautiful.
Yeah.
So that's available while the summit is going on. You look right down below the video here and you click on the button and you'll be taken over to Patrick, last name
McKeown.
McEwen.
Yes,
McEwen.
yes,
McEwen.
yeah.
McEwen. Also, I really encourage you to check out his book, The Breathing Cure. You can get it on Amazon. And really glad to see you expanding your work, Patrick, beyond I know the Buteyko field is a really great solid base, but I'm glad to see you expanding out. And I think that what you're doing is what a lot of us are doing, which is like, how do we integrate with other fields of thought and understanding and make our approach more complete and maybe less dogmatic,
Yes.
or something along those lines? I think you and I talked about in our pre chat together. And I think it's just very, very important that we recognize that there's a lot out there yet to be discovered,
Mhm,
but also that
mm.
a lot of other fields can help add into that.
Yeah, the human body is so complex, the bidirectional relationships there, you know, and we can't just ignore one aspect. We can't just focus on one aspect without consideration of others. Breathing is amazing, you know, and it really is about having you know, I really think it's having a basic understanding of physiology, but more importantly is practicing it yourself. Because an instructor who decongester knows, who practices slow breathing, who experiences improved sleep, who experiences reduced breathlessness during physical exercise, you know, if they get better asthma control, all of those things, those instructors, that experience firsthand is tremendous when we're passing this knowledge on to others. Because, you know, it gives it a degree of truth.
Hmm. Thank you. Thank you so much for being with us, and I appreciate it. And please keep tuning in with us because we have other people here in the track. Varia Doctor will be uh, exploring it from the Feldenkrais perspective. Dr. William Hong will be with us, who you recommended, Patrick.
Yes, of course. Yes.
Yes, and of course, James Nestor. So it's a really good track. And then again, if you happen to do the upgrade to the All Access Pass, you're going to get access to an incredible set of lessons on how to work with this whole tongue issue from a Feldenkrais perspective with Robert Susuma, who has an incredible orientation towards voice, which of course means towards breath. Patrick, it's a pleasure.
Thank you so much, Cynthia. It was very enjoyable.